is Orville. I'm an intensive care physician from Madrid, and I'm very pleased to start this session number 5 and to have this opportunity to chair this session about pulmonary infection. We have an outstanding panel of speakers from which I'm sure we're going to learn a lot and enjoy their presentations. There is a little modification of the agenda if you see the program. Unfortunately, Dr. Ignacio Martin couldn't make it. So, however, Francesca Rubulota from UK and Dr. Reyo from Barcelona will talk about severe community-acquired pneumonia, what is new and what happened in the last 10 years, and they're going to talk about a clinical case and discuss about on top of that clinical case. And to finish the session, Dr. Rolando Zuluaga from Argentina will talk about the new paradigms of microbiological diagnosis in severe CAP. Well, I think Dr. Reyo, whenever you want, you can start.
Thank you very much. Buenas tardes. Good afternoon. Thank you very much for the invitation to share with you my perspective on what's changing in severe CAP and participated in this important event. To the question that was formulated, I would like to reply using this outline. And finally, I will anticipate the research agenda, which could be useful for further. I think that the issue of community-acquired pneumonia has changed a lot over the past 10 years. And indeed, if you look at an important article in Critical Care in 2008, conclude that viral infections were common causes of respiratory infections outpatient, but were much less common in the ICU. It was considered that a few conditions like influenza, varicella zoster virus, or herpes virus, cytomegalovirus, and respiratory syncytial virus were common, and others were more rare, like SARS, hemorrhagic fever, and hantavirus. As a consequence, few drugs were available outside the HIV when compared to antibiotics, and the use outside influenza in the ICU was 10 years ago very marginal. And this is because the available drugs were effective only against a very extremely limited number of diseases. And an important issue regarding antivirals is that target for various points of viral reproduction. But a key issue was the diagnosis was very difficult, and it was very uncommon to have a confirmed diagnosis even of influenza in the ICU. And things were changing in 2009 with the advent of the influenza pandemic. So what was the state of the art of influenza before the pandemic? Well, I have to acknowledge that we only see a few documented cases presented as advanced ARDS. The diagnosis usually was late. Oseltamivir were reserved mainly for potential threat of biological war in powder. Most therapies were employing ribavirin, and it was no concerns in the ICU regarding influenza B, and most concerns were regarding the severity of avian influenza. It was estimated that the problem was particularly limited to severe comorbidities, immunocompromised, or very elderly patients, particularly with COPD. And all concerns were focusing in secondary bacterial pneumonia that often was a superinfection. And also, it was concerned in different media regarding potential adverse events associated with vaccination. But things have changed dramatically after 2009, and probably the most important difference is the diagnosis is very easy everywhere using PCR within 1 or 2 hours. And primary viral pneumonia was identified as a very common condition in the pandemic and later in the epidemic season. Emergence of newer respiratory viruses was associated with new diagnostic techniques, and oseltamivir became as a standard of care. In addition to the traditional risk groups like pregnant or cystic fibrosis, young obese and other populations become risk factors. And the concern, like in other conditions of chronic inflammation, was focusing in the consequences of lung fibrosis and late cardiovascular mortality. So it was reported that in the ICU, the most important concern were death by pulmonary fibrosis. Another unexpected identified complication was invasive aspergillosis intersubset with lymphocytopenia. And finally, last year was a good example with the cases of influenza B. It was reported a large number of severe myocarditis, and here ECMO became a potential rescue therapy. And unfortunately, the target remained to have higher vaccination rates. Epidemiology is changing from bacterial, the Streptococcus pneumoniae indeed as dominant, to other conditions. And this is due to several factors. One was the increase in aging, another the increase in immunocompromised and transplant patients. Also, epidemiological programs and laws that decrease cigarette smoking. But I believe that what is impacting a lot was the introduction in the year 2000 of the heptavalent PC vaccine in children, and later in 2010 the 13-valent PC vaccine in adults. So the new paradigm is that bacterial community-acquired pneumonia, indeed Streptococcus pneumoniae, may represent less than 1 out of 4 patients admitted in the ICU. And when we tested using a new diagnostic test in hospitalized patients, it is identified 1 out of 3 with viral pneumonia, 1 out of 3 in the ICU with a large percentage of human rhinovirus that probably is the much common etiology. And indeed, when we focus in hematological patients with acute respiratory failure, human rhinovirus may be as high as 50%. There are a change in the paradigm, and I think that it is critical the introduction of fast multiplex real-time PCR that allows the identification of etiologies that become difficult in the past. It is possible to have quantification of the bacterial load and identification of serotypes and reduction of turnaround. So it is possible to start with appropriate early antibiotic administration, and it is possible to identify inflammation from infectious processes and early identification of viral or bacterial infectious diseases. Indeed, 10 years ago, for respiratory virus identification, we have serologies that last 3 weeks. Tube culture or shell vial culture was very common for cytomegalovirus. Later, it was introduced some techniques which remain suboptimal, like rapid antigen detection, and more recently, it is introduced techniques of identification of RNA, and particularly quantitative real-time PCR that can split viral carriers from true infection, and multiplex assays are being very successful. And I strongly recommend to read this excellent paper published last year in Test for those who are interested. As a consequence of this, we are identifying new etiologies of community-acquired pneumonia. For instance, this year it has been reported a retrospective epidemiological study over 10 years that identified that 1 case per 100,000 inhabitants per year in the ICU is caused by human metapneumovirus. They are a predominance of B genotype. It is not only in younger, it is also common in presence of lymphocytopenia. It is typically associated with pleural effusion. 1 out of 4 are associated with superinfection by Streptococcus pneumonia, but this is severe because mortality reached about 15%. 1 out of 2 underwent mechanical ventilation and 2 hours through require vasopressor with long hospitalization periods. So this is really important. In South Korea, in Eastern China, it is common to identify adenovirus that have a specific therapies. So this is a nice figure that was reported 2 years ago in a review in which is identifying the most important achievements, and the perspective for the future is precise risk stratification, fast diagnostic molecular techniques, and particularly to start with personalized therapy. We are talking today for a large proportion of people in Latin America, and we were assessing Simone Gattarello as part of their doctoral thesis, what were the causes of non-compliance with CAP guidelines. So adherence in Latin America was only 30%, and most common causes of non-adherence were use of unnecessary antibiotics, excessive broad spectrum, particularly Pseudomonas coverage that was not required, and in severe patients with vasopressors, still some people still was using monotherapy. Recently, it has been reported newer ATS IDSA guidelines on community-acquired pneumonia, and they recommend for patients with non-severe CAP that require hospitalization but do not present risk factors for high-risk microorganisms, the combination of a beta-lactam. They reported that combination of a beta-lactam with other agents was not required. Here, it is important to remember that in a very nice randomized clinical trial in Asia, ceftaroline becomes superior to ceftriaxone, considered as a standard of care. But if you look to the subpopulation that require vasopressors and mechanical ventilation, it is strongly recommended the combination of 2 agents. In this case, if they are no contraindication, a beta-lactam plus a macrolide of fluoroquinolone to take advantage of the immunomodulatory effects. But this is not enough, because recently there are important good news. For instance, Professor Laterre and associates reported a type 2 randomized clinical trial in which using liposomes in severe pneumococcal pneumonia were associated with reduction of mortality and very good outcomes compared with the control arm. So this is open the possibility to use liposomes as adjuvant therapy to rescue patients. It may mean it is fully unacceptable that 1 out of 3 or 4 patients with pneumococcal pneumonia, which are intubated in spite of appropriate therapy, ultimately die, and it is needed a different approach that probably are not based in antimicrobial susceptibility and adjunctive therapy. And this is a good example. It is very promising, and probably here is the future. So to focus in the future, I would like to identify as requested what, in my opinion, are the top 10 research agenda priorities. One is the assessment of impact of rapid diagnostic tests, and I don't mention more because later another speaker will talk on film array and other techniques. It is needed to establish what is the real burden of human rhinovirus in severe CAP that seems that plays a very important role. It is important to do initiatives and strategies to decrease mortality in mechanical ventilation, and one of them would be the role of liposomes. It is also still needed that FAG therapy or steroids or other adjuvants have to be assessed and identify a clear benefit. And recently, we developed a research line in my research group assessing the quality of evidence in guidelines. And unfortunately, it is very low percentage of recommendations supported by high degree evidence, and it is clear that randomized clinical trials in FIND-5 and FIND-4 patients, it is clearly required and should be a priority. There are other topics that are important. One was mentioned, is the risk of cardiovascular events post-pneumonia. It is important that guidelines need to be updated using implementation systems, and probably need to be updated every year. And there are conditions which require more research. One is community-acquired pneumonic enteropics, low and middle income country. You know that in Northern Australia and Philippines and Southern India, Malaysia, melioidosis is an important problem. Scratch typhus also in the epidemic season in India, and it is needed to have information regarding this. Finally, most guidelines, more studies exclude immunocompromised patients, and it is needed to have guidelines on this subset, and particularly trials that document how to improve outcomes. So I believe that in all these conditions, it is needed, as suggested previously, to develop a personalized approach in sepsis, and I strongly recommend to read the position paper from ESMI reported in November last year in Clinical Microbiology Infection. And what is the variability? The variability is that there are some important imbalance in anti-inflammatory and pro-inflammatory response. When we have a healthy response, we are in the green area, but you know that there are some patients that have excessive anti-inflammatory response, and they are susceptible to invasiveness, for instance, for Streptococcus pneumoniae. And in the other side, there are some patients with an excessive pro-inflammatory response, particularly associated with high bacterial burden, and these are extremely at risk of developing septic shock. So I'm convinced that in the future, we would be able to identify specific phenotypes with different outcomes, and we can address a personalized approach to improve outcomes. Thank you very much. I hope you enjoyed these ideas.
Thank you, Jordi. Please don't go away. Question will be at the end of the session. And now, Francesca we'll talk about also community-acquired pneumonia, but she will show a clinical case in an obese patient. I don't think Francesca need any presentation. Everybody that works in intensive care in Europe know who she is, and I just give you the word.
Buenas tardes. Hello, everyone. It's a pleasure to be here. And of course, I think this is an extraordinary event. The conference is really successful. We have more than 2,000 people connected from the 5 continents. We are thinking together to change a little bit the format, because we're giving extraordinary lecture, but probably we are missing a little bit of interaction. So the purpose of this session, done with the help of Jordi, is to test for once a different format. You can see in these introductory slides there is the mobile of Pablo, not mine. You can send him WhatsApp, and you can find my Twitter account. You can send me questions regarding this clinical case, and the same invite obviously is for the audience that is quite larger here. So we will present a clinical case. These are my conflicts, and the clinical case is related to influenza, and then I will make some comment on community-acquired pneumonia, and this is related to a special population that is increasing quite significantly, especially actually in all over the world. And to be honest, since I've been in Spain, I've definitely been part of this billion overweight people that are in the globe. But you see, 10% of men, adult men in the world are overweight, and 15% of women, and these are increasing costs. Following the pandemic in 2009, actually, as a recent editorial has pointed out that obesity, or actually increasing weight, is an independent risk factor for a poor outcome of patients with influenza. And seems like there is a linear correlation between the increasing weight and the risk of death. This could be due to the fact that the same correlation, similar correlation, not the same, a similar correlation is also with the relation to comorbidities such as diabetes, reflux, and also because the management of this patient is quite controversial because there is an impaired, what we say, quite different lung mechanic, including compliance and so on. The problem is that it's not just the increase in weight that matters, but it's the body fat distribution, because we have more and more evidence that visceral fat is much worse than regional fat, peripheral fat. In fact, when we assess patients for bariatric surgery, we don't consider anymore the wrist circumference, but we look to the neck circumference, because this one is a much better indicator of the amount of visceral fat present in those patients. And we are now starting also doing body imagings to see the body distribution, and this is a very nice editorial showing that there is much bigger danger to be an apple compared to a pear. Why is that? Visceral fat has been recently recognized as an endocrine system, and lots of the activity related to visceral fat are part of the comorbidities we see in bariatric patients. Lots of the activity related to visceral fat can be correlated to the response that these patients have against viral infection and bacterial infection. At the end of this presentation, I will show you that actually the response can be somehow opposite. So here is the clinical case. Jordi, are you with me? So we have a lady that is 48 years old, admitted to our hospital. She has a BMI of 56 and she is smoking. She comes to hospital because she had a very mild symptom of malaria, rhinorrhea. She has a sore throat and she's sneezing. Her normal medication are few medications for her asthma. She is hypertensive, so she is taking atenolol, and she has hypercholesterolemia. She's not diabetic, so she's not very sick. Overall, for a bariatric patient, she has good functionality. But she received in November vaccination for influenza, and the reason was that she was in a hospital, and what they found is that she had gallstone. And they were planning to actually plan surgery for her. She had a little bit of nausea, but no major symptoms, and they wanted to assess her preoperatively to make sure that she had safe surgery. At the time of the assessment in November, they did blood tests, which were pretty normal, and an X-ray that looks like not too bad for a smoker of a BMI of 56. In that occasion, she went home, but in this occasion, she was not looking very well, so she was admitted, and this time she was admitted under the medics. One day after her admission, she developed severe shock. She needed intubation because she had severe respiratory failure. Her PO2 FiO2 ratio was really bad, but they managed to perform a mini-BAL and send blood tests that actually didn't show much derangement, but a mild leukocytosis. The chest X-ray changed in a day. You can see that there are bilateral infiltrates, and for this reason, she was started on antibiotics. 72 hours after, she was more hypoxic, she was ventilated 100% of oxygen, and she needed full paralysis on controlled mechanical ventilation to achieve reasonable oxygenation. The PCR for these patients came back, and regardless of vaccination, she had influenza A. So a few questions for Jordi. First of all, this is a bariatric patient, so this is she already has an independent risk factor for influenza. Is the winter. She came in December to the emergency department, and she wasn't treated with Tamiflu and Tamiflu because actually we knew she was vaccinated. So first challenge, do we need to treat those patients when they come to the emergency department given that they have an independent risk factor? And if we want to treat, and so I ask you 2 doses as an expert, do we need to change the dose?
Well, these are very important questions. Absolutely, obesity is a risk factor, and also pregnancy, and it is not different from allergic, asthmatic patients. All patients with this risk factor must receive oseltamivir as early as possible because it prevents the development of severe complications like primary viral pneumonia. An important issue is that if the patient is recovering adequately, it is possible to stop after first 5 days. But if the patient is still with acute respiratory failure and signs of active viral replication, therapy should be prolonged for 10 days. It is a mistake to maintain the same schedule that in mild influenza. What dose? It was very controversial at the initial of the pandemic, and the recommendation was to give a double dose. But now, 10 years later, as requested in the last question, we know, like other things that we learned, that in PK/PD studies that were conducted with direct BAL to no epithelial lining fluids, 75 milligrams every 12 hours by oral route is absolutely enough, even in patients with a very high body mass index, such as this one. Until 200 kilos, this dose is achieving concentrations that are active against influenza virus in the alveolar space, and it is not needed to increase. It is possible to administer in patients with a nasogastric tube using a formulation for kids, for pediatric, and should not be used the powder of oseltamivir. It should be the pediatric formulation.
So among the audience, how many of you would have thought or would have started this treatment for this patient? Can you raise your hand? Okay, so no one in the audience will do that because of the vaccination. So I think this is also a point to think, because sometimes we see some of this situation and the outcome is really poor. Jordi, when would you start steroids for this patient?
This is an important question too, because when we started in 2009, we see that these patients developed very quick proliferative phase of ARDS, and it was advocated to prevent the development of fibrosis using steroids. Now we know that this is wrong. We have several series. The SB series reported in intensive care medicine was one of the first to document that patients receiving steroids to control ARDS were associated with lower efficacy, with much more superinfections, and recently it has been demonstrated the association of lymphocytopenia with invasive aspergillosis. So the only that you will modify is to get more superinfections, longer periods of mechanical ventilation, and it does not improve survival. Steroids should not be administered in patients with severe influenza.
Thank you. Is there a role for dual therapy?
Well, because still 1 out of 5 or 1 out of 6 patients which require mechanical ventilation ultimately die, it has been considered the possibility to combine with other agents. But unfortunately, the evidence to improve outcomes with other regimens, double dose or dual therapy, in this case associating for instance, ribavirin, it is only associated with very weak evidence, and they are no recommendation to do it. Because what it seems more important is that it is not associated with an increase in the replication. It seems that it is increased hyperinflammatory hypercytokinemia response, and probably have to be modulated with some activities focusing on the host. One of the more promising studies was using monoclonal antibodies to block virulence, but unfortunately they were stopped 1 year ago because they were negative findings. So there are no evidence to improve therapy, and we need, of course, other interventions to be explored.
This patient is a smoker, and she is overweight, and she arrived to the emergency department hypoxic. In this case, we did not start antibiotic until we saw changes in the chest X-ray. Would you have started antibiotic early? Do you have any specific guidance for us if you wanted to start earlier?
Well, I think that the approach for someone that is developing with acute respiratory failure, apparently from infectious origin, it is several conditions that modulate. For instance, the possibility of opportunistic pathogens. This is not the case for this lady. So it depends if we are in the interpandemic, interepidemic season or in the 6 weeks of epidemic every year. In the interepidemic, I believe that the combination of third generation cephalosporin plus a macrolide is the more common therapy use. And in the period of epidemic influenza, until it is not ruled out, I believe that it is mandatory to test for respiratory viruses and to start oseltamivir until an alternative diagnosis is not available. Immediately post the epidemic season, and in the epidemic season, there are secondary cases of bacterial pneumonia, mainly caused by Streptococcus pneumoniae, but also an increased incidence of Staphylococcus aureus. So I believe that ceftaroline would be a good choice to optimize therapy for bacterial superinfection in these patients.
How many in the audience would have used antibiotic on admission? Hands up. So I think 20% of the audience would have used it on day one, and the other would have waited. Okay, Jordi, to finish this case and to move on the presentation, what are the key things that we have learned in the pandemic, and what are the things that you believe have changed the most in the last 10 years?
Well, probably that what we learned when we were at the medical school was not true, and this was partially related with the lack of a good diagnostic test to identify respiratory viruses. What we learned also is that the role of the host is important, and they are a big risk of primary viral pneumonia in those who do not have antibodies, and my recommendation is to improve management. First, starting oseltamivir in patients with severity or risk factors, particularly pregnant, asthmatic, immunocompromised patients, obese, and the other specific conditions that everybody knows. The second is that is a clinical need that unfortunately is not achieved, that is the need to increase the rate of influenza vaccination. This is probably the best way that we have to reduce serious complications, not only respiratory complications, also late cardiovascular complications like a stroke, pulmonary embolism, or acute myocardial infarction that could develop later.
Thank you, Jordi. So, last 4 minutes, I give you some information regarding the response that bariatric patients have against viral infection. So, effectively, because of the visceral fat, there is an alteration of the immune response, and in particular, in the case of the viral infection, there is a poor induction of antiviral immunity. This recent editorial showed summarized different pathways that have been identified over the last 5 years. And you can see in blue there is an hyperactivation of the T cells. And in fact, you will see that bariatric patients are in a pro-inflammatory state most of the time. But if you look down to the pink round cells, there is a not so efficient activation of the macrophage, and the response seems to result in a no efficacious antiviral response. What we did in our center at Imperial College, and this is the work done by Mark Almond, is that we did some mini balls and we collected blood and urine from patients undergoing elective bariatric surgery. This means that those people were not infected with the virus. We collected sample and we incubate those sample with 3 different types of influenza virus. You can see here on this slide only one example where the cells, the epithelial cells from the minibar were incubated with influenza A virus. You can see that activation of the pathway is absolutely normal. The influenza virus goes into the cell, so there is the normal endocytosis, and the pathway-associated molecular activation is normal. So you have activation of toll-like receptors and release of interferon and interleukin. In fact, you can see from other publications that the visceral fat of bariatric patients has increased level of TNF and increased level of interferons. So the pro-inflammatory state of those patients is evident. But then what happens? In the blood of this patient is an increased level of leptin, and it seems that the leptin is the reason why the activation of the pathway is not completed. The macrophage feel the signal of the interferon, but they are not able to transmit this signal inside the nuclei. So what is called the SOC receptor are blocked by the leptin, and we don't know exactly by which mechanism induced by the leptin this blockage does not allow the bariatric patient to have a normal response against viral infection. Is that all? Well, that here comes the funny thing, and what I want to conclude with is what happens is instead of a viral infection, the bariatric patient had a community-acquired pneumonia like Jordi talked at the beginning of this presentation. This is a study that looked at more than 1,000 bariatric patients. These are not very large patients. In fact, the mean BMI is 30. You can see survival at 30 days of patients of a BMI around about 30 is better than normal patients. Well, recently, I didn't have time to present. The results of the PRO-B study show that there is no difference with the protective ventilation provided to those patients, so it must be something else. If you see the curve here, patients that are super slim with a low BMI have a worse outcome, then the curve becomes flat, improves, and then after 45 of BMI, mortality increases again. And this curve is incredibly similar when you look to the risk of dying for any of the other comorbidities. It seems that for some sort of reason, patients that are 30 to 35, instead of being overweight, are somehow protected for a group of disease and affected more for another group of disease. And most of the time, we don't think about this variability when we treat patients coming to our intensive care. So that means that except I take a virus infection, having been in Spain and increased my weight, I'm protected if I get into the intensive care. And the reason, once again, is the visceral fat. And we don't know much about the visceral fat, but we are creating a bank from our elective patients where we will look at the monocytes and the response to this kind of infection. Is this only one study? I don't have time to go into details, but this is a series of studies that have recently and not so recently been published looking at patients in Europe. This is a patient in Japan. You can see that BMI in those is 25, but for Japanese obviously is overweight. And this is looking at 110,000 patients, suggesting long-term benefits after admission to the ICU if the patient as community-acquired pneumonia. The study for Le Croix, looking at 2,600 male patients, survival is improved. And most of those studies, including the one looking at ventilatory-acquired pneumonia, not just community-acquired pneumonia, suggest that the patients have a pro-inflammatory state. What does it mean? It means that interferon response is activated. Does it matter? Well, we only have the outcome, so we don't know the process that leads them to have a better survival. But it's a question to be asked, and we don't have responses. And when we get patients coming to the emergency department, we need to ask ourselves the question, do we need to give antiviral? Yes, potentially we need to give it early because the patient is obese. Do we need to give antibiotic? I don't know, because actually those patients do better, so we might wait a little bit longer than given that on the front door. And obviously it's very much clinical judgment, but think as a final message that the visceral fat is an endocrine system, is an independent system. Who is provided with visceral fat has a very different behavior compared to the rest of the population. No scoring system is looking about this variable, and no big database is still looking to account this feature. So I think my time is over, but before leaving you, I would like to invite you to a conference and to leave you my contact if you are interested. This is a conference that will be done next summer, and it's looking at diversity and equality and looking at the future of intensive care, which I suspect will be more important across the globe in developing countries, and more important given that 70% of students in medicine are female. So thank you very much for your time, and I hope you have sent questions to my Twitter, so we might answer at the end.
Thank you, Francesca. Now to finish this session, I'm going to present Dr. Zuluaga from Argentina. He is the chair of the specialty of clinical microbiology in Catholic University in Argentina and associate professor of microbiology in the University of El Salvador. He's an expert in new molecular test diagnosis in pneumonia, and that is his talk about the new paradigms in diagnosis of severe CAP. Dr. Rolando, whenever you want.
Here you can see the introduction. Next slide. For the microbiology lab, it's essential to know whether we have a patient of CAP, if it's severe, if it's mild, if it's nosocomial pneumonia, or whether it is on ventilator. If the risk factors give rise to other types of issues, or if it has all sorts of infections. Next slide. Why is this necessary? Well, because we may need different samples, different processing, or even a different interpretation. Next slide. With regard to samples, next slide. If we talk about CAP, or nosocomial pneumonia, then the sample to begin with is the sputum. That is for nosocomial pneumonia, that would work as well. If the patient is intubated, then we can choose other samples such as bronchoscopic or mini ball, for instance, or tracheal secretions. Also, we can have a isotope test or a nasal aspiration, the lung biopsy, blood culture. Lung biopsy is only for those cases where the patient does not respond and we do not know what the diagnosis is through other tests. Blood cultures are important in 20% of the cases. Also, urine tests are important for antigens that are present in the urine. And of course, with regard to the diagnosis, this is important for really acute pneumonia that needs hospitalization. Next. Microbiological studies. We can apply conventional microbiology through a direct test, cultures, urinary antigen for S. pneumonia and Legionella, and also new methods such as serology for mycoplasms, chlamydia, bordetella, bornetti, Legionella, different mycoplasm virus. But this should be the classical methods, but then the new methods would be a PCR, a qualitative PCR, especially for virus, mycoplasms, chlamydia, etc. Next slide. With regard to the traditional biological diagnosis, if we talk about the gram staining in CAP, sensitivity is lower, but the specificity is very high, over 90%. And in this case, if we see a morphotype that is predominant, then this could help arrive to a microbiotic therapy, and that helps with culture as well, especially blood culture. What happens with nosocomial pneumonia? In this meta-analysis, we can see what is the sensitivity of gram staining, which is 79%. Next slide. And specificity is 74%. But the values are very variable depending on the studies, which makes these authors to conclude that if we do not see any gram staining, then that is no significant in order to see what type of therapy to apply. With regard to the urinary antigen, this agrees with previous studies because it's a sensitivity for pneumococcus of 74% and specificity is over 90%, in fact 97%. What happens with culture? We need to do blood culture, chocolate culture, McConley cultures, depending on the serology, also sputum samples, and we need to do it from a semi-quantitative point of view. And for the different type of test, it could be quantitative. Then the seeding of these should take into account mycobacteria and fungi, and also it could be the same for these immunosuppressed patients. For aureus and cepaceae should be the same, especially FQ. With regards to culture unfortunately have down and a lack of advantage because it takes a long time, 48 to 72 hours for typical bacteria. What happens with quantitative culture for these tracheal secretions or a mini valve, for instance? Well, taking into account the cutting point of each of them, as you can see on the slide, there is no significant change with regard to the specificity or sensitivity. This means that choosing one or another will depend on each hospital, the experience and expertise, and the chemical impact of each of them. Next, let us see what are the fast diagnostic tools.
This 323 cases in the United States showed a PCR 86% versus 39% with culture. 90% of the positive ones had a positive PCR. If we look into the bacterial agents, PCR detected 81%, but when PCR quantitative was applied, this was reduced to 21%. This means it is necessary that it needs to be quantitative. More than one bacteries were detected in 32%. In the many cases these viruses were co-acting with bacteria. In an 85%, the patients were treated with antibiotics, 78% with a PCR versus 32% with a culture. Nor the positive culture nor the PCR nor the bacterial weight or load was associated with the severity of the situation. But the important thing is that the result of the PCR led to this scale up of a de-escalate of a 77%. Contrary to what I mentioned before, other articles or other studies also found a correlation between the bacterial load and the septic shock and the severity of the infection. If we compare further between culture and PCR, we find 3 studies. Johansson with 128 cases with the PCR was positive in 27%, and the culture only half of it. 80% of patients had antibiotics. Or the Straling case study with 112 patients with 32% positive sputum and PCR 53%, and Holter in Norway found diagnosis of 84% with the conventional diagnosis versus 63% in the PCR. So this is a result that happens again and again. What happens in the nosocomial pneumonia in this study with a PCR? In this case, the presence of certain microorganisms was incremented, but in this article the authors didn't talk about quantifications, and maybe some of them have been overestimated. Next, please. Nevertheless, this led to a 67% cases with a different treatment applied. What happens with the Legionella? In this case, next please. Detection, back please. Detection with PCR in respiratory samples has a very high sensitivity, 97% and 99% of specificity. But PCR in blood, in urine, lowers the sensitivity to half of it. In the case of urine antigen, sensitivity is around 77%. If it is combined with the PCR and INVAL, and next please, we obtain the best values of prediction, both negative and positive. So this combination is advisable. As for the mycoplasma, today PCR is the fastest method, the most specific one in comparison with culture and serology. And the same, we could do the same with the Chlamydophila pneumonia. Very same considerations. Next, please. The tuberculosis TB. This is a very interesting study by Cowan analyzing the group of AFB smear with sputum with bacilloscopy positive. It had a 94% of sensitivity and the determination of two experts of 80%. The interesting part here is that if we part from negative bacillocopias, the specificity was around 75%. In the case of Aspergillus, an important issue, for instance, the neutropenics, combination of the BAL and PCR and galactomannan, the best combination of sensitivity and specificity, 90% and 94%, at least in this meta-analysis. The pneumocystis jirovecii, normally in diagnosis, it is done with a combination with different materials and substances. But again, the easiest and specific method is PCR. However, there is a detection of pneumocytic in asymptomatic patients, so it should be quantitative. The problem is that there is not a cut point under consensus, and the different methods give very different results. So it's still pending contrast. We should improve the performance of the detection of these jirovecii. Next, please. This meta-analysis shows a 98% of sensitivity and 91% of specificity with PCR from BAL for pneumocystis jirovecii. These are really interesting data, considering the previously mentioned limitation. As for respiratory viruses, I think there have been very interesting speeches talking about this, but the viral culture and the DFA had been the reference treatments, but they require time and experiences. Then the EIA showed very low rates of sensitivity. In the end, the multiple PCRs have been found to be very efficient. This is a very interesting article by the Revista Argentina de Microbiología, where we could confirm the detection of more positive PCR than in the traditional method that had been used so far. And furthermore, there was more detection of polyinfections. And the same is showed by this study, where there is a comparison of viral culture, FARP, and ES-RVP pathogen. Now, what is the impact of all this? Again, in another study, we can show that it is important to change the diagnostic method, and it is shown that there is a reduction of additional tests in pediatrics. This here is a new panel by film array for typical bacteria expressed in semi-quantitative samples with critical genes of resistance like Legionella, Mycoplasma, and viral agents, and Chlamydia pneumonia. This here is a multi-center study from Argentina, 5 hospitals working here, where we detected 51% of co-infections. This is something that has been repeatedly seen in other studies. And we detected 1.5 more presence of bacteria, more pneumo, more Moraxella, Staphylococcus, and Streptococcus group B. And next, please. We also detected significantly more quantity of cultures of different variations of these agents as compared to the typical traditional methods. And the most relevant aspect of all is that it enhanced changes in therapeutic approaches in 74.6%. In 21%, it was decided to broaden the spectrum. other methodologies that maybe in the future will be very valuable. Nowadays, we lack evidence, are far to be applied routinely, automatized microscopia, hybridization, fluorescence in situ, PCR combined with mass spectrometry, and metagenomics and microbiomics. And to conclude, we face certain needs. We need to have a proper choice of the best treatment from the very beginning to avoid unnecessary ABX. For that, it is critical to understand the local epidemiology and have very fast tests. Then the traditional microbiology shows very variable sensitivity and specificity as compared to gram staining, and the results take some quite rather long time, and then the bad quality or poor quality of the tests of the samples, and also very little sensitive tests also are some issues. As for molecular biology, PCR increases sensibility, and it should have a broad coverage of microorganisms and mechanisms. It should be easy to implement with results in a few hours and be cost effective. Well, I apologize for the technical inconveniences. I thank you for your attention. And this was the end of my presentation with a landscape from Argentina. Gracias, Rolando. We need to have a break here, but maybe we have some room for 2 short questions. Rolando, there are many countries and development countries who are listening to us. Do you have any experience with molecular diagnosis? Which of these tests is the best, the more cost-effective that could be recommended for low-income countries? Well, that is an excellent question. When we analyze cost-effectiveness of a test, we don't not only need to take into account the cost of the test, but also analyze the pharmacoeconomy whole study. So what are the antimicrobial times, exposure of patients to nosocomial infections? So depending on the reality of each country and depending on the reality of each institution, these techniques have proven to be cost effective. At least in our experience in the Naval Hospital, these have proved, well, we have experience with FilmRI, we have proved therapeutic changes that are significant, not only with the pneumonia panel, but also with sepsis and meningitis panel in articles that have been published previously. But my personal opinion is that to analyze from the pharmacological and economical point of view. Okay. Now, Jordi, la última pregunta y ya con esto cerramos la sesión. La terapia dual, ¿durante cuánto tiempo tendríamos que mantenerlo en la neumonía adquirida en la comunidad en casos graves? Creo que no hay una respuesta exacta. Lo que es importante es empezar lo antes posible.
What you are looking is the decrease in the bacterial burden and the maximal bacterial burden as at the beginning. So what it is important is to start as early as possible. Second, probably the macrolide has more rationale to be maintained by the immunomodulatory effect until they are inflammation. So for eradication, I believe that it is enough 3-4 days. But when the patient is intubated and has an important inflammation, standard of care is 1 week.
Excellent. Well, thank you very much to everyone. And if there is any more question if there is no any more question, then we close the session and move on to the next one. Thank you, Rolando. Thank you, Jordi. Thanks, Francesca.
Muchas gracias.
Thank you. Gracias.
Thank you.